Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for January 20th, 2021. Thank you for joining us this month. Our presenter today is Mary I. O'Connor, MD. Dr. O'Connor is a nationally recognized leader in health equity. Since its inception in 2010, she has chaired the Movement is Life Caucus, a multi-stakeholder coalition committed to addressing musculoskeletal health disparities. She is Emerita Professor of Orthopedics at Mayo Clinic and Professor of Orthopedics and Rehabilitation at Yale School of Medicine. As an entrepreneur committed to patient-centered and value-driven care, Dr. O'Connor is also co-founder of Voya Health, a new musculoskeletal medical startup company. In February 2021, she will become the Chief Medical Officer for Voya Health. Dr. O'Connor's presentation today is entitled Movement is Life's Operation Change, a Model for Community Engagement. Welcome, Dr. O'Connor.
Thank you. Thank you so much. I'm delighted to be with you today. Thank you to our listeners for taking the time to join us. This is, I think, a great Lunch and Learn series, and I'm excited to share with you our experience with a community-based engagement model that we have piloted in several locations. So I'm going to start with basically, let's see, let me advance the slides. Okay, there we go. I think it's helpful for us to just take a step back and look at the big picture about what contributes to our health. And if we look at the bottom of this figure, we can see that medical care actually contributes 11% to overall health and well-being. It might seem a little strange to people that are healthcare providers on the webinar, because obviously when you need medical care because you have an urgent issue, it could fundamentally change your health and your outcome. But when we look at the overall contribution, that is still a relatively small contribution, because we see that the environment at 7% and social circumstances at 24% certainly collectively contribute essentially 3 times what direct medical care would contribute in terms of our health and overall health outcomes. And that makes sense, because if we live in a neighborhood where the air is bad, chances are we're going to have asthma, or our children will have asthma. If we live in an area where it's unsafe to walk, it's more likely that we will be obese and have low levels of physical activity. Genetics is important. We know that family history matters, but by far the most influential aspect of our health is our individual behavior at 36%. And so at Movement is Life, we really looked at the issue of how can we help communities become healthier, and recognized that we don't have the ability right now within our own coalition to clearly alter social circumstances or the environment, and certainly no one can impact genetics. We know that there are challenges with access to medical care, but we looked and said, what can we do to try and support individuals developing healthier behavior change that would then improve their health? And is there the ability, the social situation within which that individual is in, to help influence that outcome as well? So we had these concepts in mind. We have what we call the vicious cycle. And this is really fundamentally what I think probably everyone on this webinar understands and appreciates, which is if an individual develops joint pain, they limit their mobility, which leads to a lack of physical activity, promoting obesity, which then puts more pressure on the knee joint, for example, and you get worse joint pain, and you have this cycle. And that cycle, of course, can result in end-stage osteoarthritis. We know that this cycle is disrupted by movement, because is healthy for our joints. It decreases joint pain. Movement improves our level of physical activity and combats obesity. But we also know that with obesity and lack of physical activity come the development of significant medical comorbidities, namely diabetes, depression, heart disease, and hypertension. So, what we'll see here is that anybody can get trapped in this vicious cycle and end up with bad joints, obesity, diabetes, hypertension, the kinds of patients that I certainly see in my clinic all the time, and I'm sure many of you see. But when we look at the larger picture and we see this inner circle, which is the medical vicious cycle, and we understand that anybody can get trapped in this cycle. You could be an affluent, wealthy CEO of a company and get trapped in this cycle. But we know that women and individuals of color are more likely trapped in this joint pain vicious cycle. And that's because surrounding the medical joint pain vicious cycle is this green ring of social determinants of health. Okay. So we know that zip code influences life expectancy and influences health. We know there's disparities. We know there are issues with literacy and education, employment, access and utilization of healthcare resources, structural racism, unconscious bias. So this green ring of social determinants impacts patient getting trapped in this medical vicious cycle and helps us understand why women and individuals of color are more likely to get trapped in this cycle. And then surrounding that green ring of social determinants are public and private policy. For example, how we pay hospitals for procedures, how we pay providers. And we are probably, most of us are familiar with efforts to drive, quote, value-based payments. And one of the challenges with those value-based payments is that they do not typically risk adjust for patient comorbidities or socioeconomic factors. And that can lead to cherry picking of healthier patients and lemon dropping of unhealthy patients. And when there is financial incentive to the provider to have lower healthcare costs. So we know that public and private policy, and I just use value-based payments as one example of how those policies then influence social determinants and influence the medical vicious cycle. And then this year, unfortunately, I had to put this new ring, which is labeled pandemic, around the entire visual, because we fully understand, well, we fully appreciate the horrible effects of the pandemic on communities of color and how they're being disproportionately impacted. So it was clear to us at Movement is Life that we certainly need to be working at a community level to try and impact health and how communities become healthier. So we created an 8 community-based program. We called it Operation Change. To be eligible for the program, we needed the women to be obese and have knee pain. And the program was 3 hours once a week, as I said, for 18 weeks. And the first hour would be an education topic. For example, nutrition or education about diabetes or depression. And the second hour would focus on movement. And this would be typically physically easy activities, but to get people moving. And of course, individuals could participate at different levels based on their physical ability. And the third hour was focused on motivational interviewing, where we divided the group because the total number of women in these groups was about 45 to 50. So we would break them up into smaller groups for motivational interviewing. And they would be led by a facilitator. And the goal of this hour was to really help these women understand what their personal barriers were for adopting healthier behaviors. And for them to talk about that in their small groups and and gain insights and strategies for how they could become more effective at adopting healthier behaviors. And this is just an example of one of our cohorts, an African American cohort. And you can see the woman in the front who's leading this movement activity. So, what we saw in our first 5 programs, where we had about a little over 200 participants, was over 18 weeks, a 3% decrease in their weight, a 35% decrease in their knee pain. And this is without no drugs, no injections. This is just them moving more, and that movement helps their knee pain. Their walking speed increased, I think, an impressive 18%. And we saw a nearly 40% improvement in their feelings of hopelessness. Because as a group, these women were actually depressed or borderline depressed. And so I found this to be personally a very hopeful statistic from the program. And again, all without drugs, injections, or medical interventions. So one of the sayings that I like, which I'm really not sure who came up with it, but in researching this, it's attributed to a newspaper journalist named Charles Ropel, and this was decades ago, who said that illness can be transformed to wellness when we move from I to we. And I just think that is such a powerful statement, because one of the things that we found in our experience with Operation Change was when we asked the women what they liked best about the program, I certainly expected we would hear things like, well, I'm moving better, or my knee hurts less. But what we heard from them was how meaningful and important the relationships were that they formed with each other. That's what they liked best about the program. They liked meeting and connecting with the other women, and they found support with the other women. I mean, we even had women say that this program saved their lives, and that they would come every week because they wanted to be there to support their sisters. So one of the things that I learned from our experience with this is this power of the emotional connection that people need in order to make successful behavior change. And I see a lack of that in our current healthcare system, which is fragmented and siloed, and it's very, of course, periodic, right? I mean, even if you have a great relationship with your primary care physician or primary care team, you know, you're not seeing them all the time, and they're not really kind of understanding what you're going through in your daily routine and your normal life. And one of the powerful things about this program was that we created the cohorts based on race, ethnicity, so that we had African American groups, Latina groups, and then we also have had a Caucasian group in rural America, in Kentucky, where there are severe health like just like we see in poor neighborhoods in large cities. So one of the things that I think was powerful about that was that the women um, could more easily identify with the other women in the group because they looked like them. It also allowed us to tailor some of the educational content to ethnicity. So that, for example, the cooking classes, when we talked about nutrition and cooking, it could be focused on ethnically aligned foods. When we would do the classes, the music could be music that would be culturally aligned. And so I think that really supported the women making these emotional connections with each other, that when they move from I to we, that helped them make transformative changes in their lives with their health behavior. So that is the end of the slideshow. I think I'll stop sharing and open this up for questions, because we feel very strongly that if we cannot effectively reach out into communities and impact the health of communities at a community level, we will not be successful in improving health in this nation. And we certainly need to do that. And that has become ever more critical apparent with the pandemic.
Thank you so much, Dr. O'Connor. And for those of you, thank you for some questions that have already been submitted, and I'll read those aloud in just a minute. For the rest of you, please feel free to type any questions into the chat box. First, there's a question confirming the length of the class. Did you say it was 3 hours long? And I actually had a similar kind of follow-up question to that is, what is generally the completion rate for participants?
So those are excellent questions. And I can see in the chat box who asked. So Nicholas, thank you for the question. Each weekly session was 3 hours. And we divided those 3 hours into 1 hour segments, with the first hour focused on some type of more didactic educational presentation. Could it be about nutrition? Gregory asked a question about whether we included pain education, and the answer was yes. We talked about pain education as well. And these first hours when we presented educational content was very well received, particularly as we very focused on delivering the information in a easy to understand, minimal medical jargon approach, because these individuals are not medically trained, but that doesn't mean they're not intelligent, right? I mean, they can understand this information and these concepts if it's presented in a way, in a language that allows them to get the concepts. So yes, we did include pain education, because that also linked to depression and catastrophizing. And again, the second hour was the movement time, when we would do some type of movement activity with them. And the third hour was motivational interviewing. So each week of the 18 weeks, the women did those 3 segments. The question about drop off or drop out, or people that didn't make it, it was amazing how many women came each week. I mean, we even had a couple women change around their personal family schedules because they didn't want to miss a week. They were so engaged in this community that they didn't want to even miss one session. When we finished with our program in Kentucky, then we're like, you can't go, you can't leave us. We have to keep on with this. We want to continue the program. And we said, well, that's that's fantastic. We're really happy that you want to continue the program. We have not budgeted, nor is it part of our strategic plan to extend the program here. But they started to seek local funding. So a couple of them went to the mayor's office and said, this is such an important program. We need some support from you in order to be able to continue it. But then, of course, the pandemic came and all of this was shut down. So we have not had, as you can imagine, any face-to-face programs since the end of 2019, because the pandemic we were start programs up after the holidays in 2020, but we had to abort them because of the pandemic.
So do you see Operation Change as kind of a permanent program, and can it be implemented in other parts of the country?
Absolutely. So we see Operation Change as a program that many communities could implement. Um, it's you don't need you need people who can be trained to do the program, but you don't need high level medical professionals. By that, I mean you don't need physicians. You need some people who can train, or we've done the train the trainer model, right? Where we've trained some people because they're local people who support the program, and we will have a facilitator that we train and an organizer so that the programs are reasonably consistent because we want to understand if the program's working or not. And I would say that we are still looking forward to gathering more data and having a broader experience um, than our experience to date. However, we're very encouraged by what we've seen. So the whole concept that this is a program that communities would embrace, that you would set up these uh, groups of women to go through the program and then basically improve their health behaviors. Now, I think the program is applicable to men as well, although we have not piloted it with men. Our focus has been on women because we know that women are have higher rates of obesity. They have higher rates and levels of knee pain. We're not promoting knee replacement surgery, but we do know that there's disparities in utilization of knee replacement surgery for women. So we just know that women have a higher disease burden and are more significantly impacted by osteoarthritis, and hence, with our first programs, we focused on women. But I believe this type of approach could be equally effective with men, although we have not piloted that to date.
And if there were an organization that was wanting to implement Operation Change, do you have an estimate of the cost,
Mhm.
as
That's
well
an
as
excellent
kind of
question.
what the process is for kind of applying or for getting the information
Mhm.
about how to start it?
S- Lee Callahan, thank you very much for that excellent question. And thank you so much for inviting me to participate. I'm just delighted. And Dr. Callahan is a member of our Movement is Life steering committee. And we are just, she's been such a fabulous supporter. And I'm always eternally grateful for her mentorship and support and guidance. So the cost, to get to the question, the cost of the program is about 25 to $30,000 for this 18-week program. And that really is to supply, to support the facilitators that you need to run the sessions and for some expense of the sessions. So it's not very expensive. When you look at I don't think it's very expensive when you look at other community interventions and costs of similar programs. We are looking for, once we get past this pandemic, and realistically, as much as I would like it to be sooner, I honestly don't think we're going to be getting back to having Operation Change programs until 2022. I think we're going to need the rest of this year, calendar year, to get the population vaccinated. Hopefully that will happen sooner, and maybe we can start, later this year. But we need people to be safe in order to get together and and create these social communities that then allow individuals to support each other to affect the behavior change. For these women, one question that I don't have an answer to is, could you accomplish something similar in a purely virtual setting? In other words, could operation change be on Zoom? And how well would it work if you did it just on Zoom? I think for the populations that we've engaged with, there would be some challenges in terms of their ability to connect, in terms of internet access and connectivity. And I also think that this is just my opinion, my bias, because we don't have any data on this, that there would be some loss of the ability for these women to make connections with each other. Um, I think all of us have experienced this. I can say I experienced it in this pandemic. I miss um, the connections. I'm on Zoom for hours each day at times, and it's still not the same. So I do think that we're human beings. Human beings need connection with other human beings. And while there's certainly opportunity to leverage uh, virtual interactions or even virtual classes. For example, I could envision that the didactic sessions could be delivered by a virtual presenter. I think that this that we can that we still have to focus on people being together face to face and supporting each other.
Thank you,
I
Dr.
kind of
O'Connor.
went off on that tangent, Katie, but
No, that's great. That was a question on my mind as well with the virtual nature that we've been forced into, but it seems like really a huge component of Operation Change is the bonding and kind of the relationships that happen during and maybe even outside of class.
well, that was one of the huge learnings that I took away from it. You know, I'm an orthopedic surgeon by training, and I did not expect that the fundamental driver of why these women improve their health, it wasn't the education that we provided. It wasn't the movement class where they learned that they could actually move more. It was fundamentally the motivational viewing and the connections that they formed with each other. That's what drove the success. And so when we're thinking about how we're going to engage community to improve health, I think that we should all be thinking about how those factors can be incorporated into programs. Because if it's just education or if it's just a movement class, I don't think that that's going to be sticky enough to actually um, affect behavior change for individuals.
That's really important to remember as things get back to normal, is not just kind of relying on all of the virtual systems that have been set up.
Correct.
So we're going to take one last question here. There's a question about whether or not you might consider opening Operation Change to non-NEOA populations.
Yes, I see that. Thank you for another question. Uh, the answer would be yes, um, but not right now. I mean, like we we want to broaden our outreach with the current program, and of course, the patients that have knee pain who are obese, they often have pain, which, as we all appreciate, is so ubiquitous in this country and in communities where individuals are obese. It's incredibly common that they also have low back in particular and even hip pain. We did not exclude women from participating in Operation Change if they also had back and hip pain. So many of the women in Operation Change also had pain in those areas. But in order to get into the program, they had to have knee pain because we simply had to start someplace. We did not focus on looking at the impact of the program on hip or back pain, but certainly would envision we could expand and would expand into those areas at some point in the future, because it's all connected. I mean, if you give people education and you get them to move more and increase their level of physical activity, then it's also going to help their hip and back pain. Although targeted education and even some perhaps some specific movement based I don't want to say exercises, but movement based activities could be incorporated that would more effectively address those anatomic areas.
That's great. Thank you, Dr. O'Connor. So we'll definitely be expecting to hear more and see more, hopefully, of Operation Change after 2021 and as we move into 2022. We thank you so much for being here, Dr. O'Connor, and thank you to everyone in attendance today. I'm going to just initiate a poll here that, if you don't mind taking before you hop off, and just remind everyone that we will have another Lunch and Learn on February 17th, and the title of that will be Walk with Ease, Moving Forward Despite COVID-19. And that presentation will be moderated by Serena Wiesner of the OA Action Alliance, and will feature lessons learned from two community organizations, the North Carolina Center for Health and Wellness and the National Kidney Foundation, as they continue to offer Walk with Ease during the pandemic. So thank you for joining us
And
today, and that
Katie,
concludes
can I
today's
just
presentation. Yes, go ahead.
Katie, I just want to, for all the participants, when Katie sends out a follow-up note, I'm going to ask her to include a link. I just gave a TEDx talk about your power as a health promoter, and I would so appreciate it if you could take 14 minutes and watch my talk and provide some feedback to me, because I talk about Operation Change in the TEDx talk, although I wasn't allowed to say it was labeled Operation Change because of TED rules. But I talk about our experience and some of the lessons that we learned, and how fundamentally each of us can be a promoter of health for those around us. And that's one of the things that I learned from the women in Operation Change. So thank you, everyone. Have a wonderful day.
Thank you.